Okay, welcome to Spine Conference. Today's discussion, because who asked me to do cervical radiculopathy? I forget. One of the some physical therapy. So I like to do case-based learning. And Katie, you've not seen this case, right? You don't. I don't think so.
I don't think so.
So, 56-year-old woman. Her chief complaint is left arm pain, cervical radiculopathy. She has pain and numbness in her left neck, and it goes to her left thumb, index finger, and middle finger, and it started 6 months ago. Past medical history is hypertension, diabetes, bilateral total knees, cholecystectomy, gout, sigmoid colon resection for diverticulosis twice. She takes metoprolol, statin, metformin, buspirone, duloxetine singular, metoprolol, lisinopril. She's a right-hand dominant clerical worker. 5'7", 251. Her BMI is elevated at 39. And her symptoms are definitely recreated with range of motion of her neck. So it's been 6 months. So what questions do you have, Katie, at all? Any? You don't have to have any questions. You know. Okay, we'll keep going forward. That's fine. So what do you see on the X-rays? How about C5, C6? Anything abnormal?
C5, C6 disc is a little
bit flat, a little bit flat, yeah. And I think posteriorly there's a little bit of an osteophyte. You see posteriorly at C5, C6, the bone is going backwards towards the spinal canal some. Do you see that?
Now that you mention it.
Yeah, it's a little subtle finding, but it's definitely there. On the AP view, the uncus is a bit osteophytic at C5, C6. Can you see that? I don't have a pointer, but,
No.
huh?
You forgot the pointer.
Yeah, I don't have my laser pointer. It's right there. See that osteophyte? A little bit. Do you see that or no?
On the left?
On both sides.
Oh, on both sides.
Right here. Okay. See that?
Okay.
See, it's a little bit. The uncus, it's hypertrophic there.
Okay.
And that's a subtle finding on the X-ray that tells you that the uncus is osteophytic. And now in the oblique view, it's more obvious. You see in the foramen, the hole where the nerve exits, you see how the uncus is osteophytic at C5, C6, and it's compressing the nerve. So basically the findings, I think, are just C5, C6. Does that correspond with the patient's symptoms, C5, C6? C5, C6, remember the cervical is one level lower, so it's C6 nerve root. C6 nerve root goes to the thumb. Yeah, so it does correspond. Good morning, good morning. Well, yeah, welcome. All right, so we'll go to the experts so far. Walter, this is your patient, 56, left C6 radiculopathy, 6 months. How would you treat this patient?
Well, typically, you want to abate some of the inflammatory response. So if she's uncomfortable, I will probably give her a boost of steroids to bring the inflammation down.
Just a week?
Yeah, just a week, just to abate some inflammatory response. If they have the same pain, I usually provide them a trial with physical therapy, a little bit of cervical traction, to create some breathing room.
You said home physical therapy, or just in the therapy? Or?
Regular physical therapy directed. Supervised physical therapy. If they respond to that, usually they will respond within 3 to 4 weeks. If you're going to get any response. If you don't, then we move on to a second tier of treatment, which will be the epidural injection. It's just to deliver the steroid right where you need to. It will give you the...
Do you have them come back in the office?
Yes.
2 weeks?
4 weeks.
4 weeks?
Within 4 weeks.
So you say physical therapy, steroids?
Steroid, activity modification.
Non-steroidals following the steroids or no?
I'm sorry?
After the steroids are done, after 7 days, do you give them something else?
No, usually don't.
Just steroids.
If they are taking anti-inflammatory medication for pre-existing osteoarthritis, they can keep taking that. But I usually don't, because it just avoids the diagnostic properties of that short course of steroids.
Yeah.
If they still have symptoms, then I move on to the second tier of treatment, which is the epidural injection, just looking not only for therapeutic qualities of it, but also the diagnostic purposes.
You get the MRI before the epidural?
Well, Yes, you have to.
Okay.
You have to because you have to differentiate. You know, you want to be sure you put a needle on close to a soft tumor, a cyst, or something like that.
Right. Okay. So you see the patient back within a month, and you ask them, "Did the therapy make you feel better?
Mhm.
Did the steroids make you feel better?" If they say yes, then you're good. If they say no,
We move on to the diagnostics
diagnostic MRI scan. Let's see what's wrong,
and the epidural injection.
and possibly an epidural steroid injection.
That's
Maybe
right.
set them up with pain management.
That's correct.
Okay.
We usually try to avoid the pain medication if possible, but you know, the epidural injection actually provides them significant relief, and we're talking about over 50% relief with the first or second shot. That will give you a pretty good idea where the pain is coming from and in the prognostic. If that lasts, bingo.
Okay. All right. So here's the MRI scan. This is low resolution study because it's an open MRI. And Katie, can you tell everyone any obvious findings?
There's stenosis at C5, C6.
Yeah, C5, C6, and it looks like there's a disc bulge at C6, C7, right?
and C6.
Two levels, yeah, C5, C6, and C6, C7. So this is a fat suppression image, and this is a sagittal cut, T2 weighted image. Does this change anything? It's about the same, C5, C6, C6, C7 disc bulges?
It's the same.
Okay. And so here are the axial cuts. What's that circle? And tell Jenny what that circle thing is in the middle.
So the axial cut is we're looking at the spine, and just picture if the patient is laying flat on the table and the feet are sticking up at us. That's how we look at the spine. The circle in the middle is our cervical, is our spinal canal, that black circle in the middle. And we like that whiteness around, that's the spinal fluid.
Spinal fluid around the spinal cord.
It's enough of room. So C3, C4 looks good. That's
So-
how it should look.
So axial cut looks good. C3, C4,
It
spinal
does.
cord looks good. How about C4, C5?
It still looks good. There still is spinal fluid on that.
What's that little, in the very center of the disc, what is that thing that's going towards the spinal cord? That little, what is that?
A little bit of a herniation.
A little, yeah, something, either a herniation or a bulge.
But it's
central.
not causing any central canal stenosis.
Or yeah, probably an osteophyte. Okay, C5, C6?
So this is the problem area that we saw in the sagittal cut. So you don't see that white circle like you do the other levels. So
No CSF about the spinal cord, right?
what's that?
No CSF about the spinal cord. But the CSF should be around the spinal cord, and that's
Correct.
gone now.
Correct. No fluid around the spinal
The
cord.
basement of all the fetal space is just obliterated, so all becomes homogeneous
Mm-hmm.
on this segment.
And this is a C6 inferior end plate, and C6, C7, and C6, C7 disc space. And can you see on the left that disc herniation, that soft disc herniation? I don't have a pointer, but you see the spinal cord. Just on the left, there's a soft, and there's a C7 superior end plate. See that on the left,
Yeah.
that soft disc herniation? And I say it's soft because the color is bright as compared to the rest of the disc.
Okay.
The magnetic sequence equals the center of the disc. You see it dark, it's more dense, usually bony in this side.
Okay, so, and here's a video. This is an axial cut. Axial cut's a video going down the spine, just to help you different view. That's I think that's C4, C5. No, that's C4, C5. And C5, C6, there's pressure on the spinal cord. And again, C6, C7, see that's the thing on the left, yeah. Okay, so, all right, so Walter, she's back in your office with this MRI. She's still having symptoms. The steroids did not help, the physical therapy, although most people, I have found when people go to physical therapy, they appreciate it. They say they really helped, but she said it helps when she was there, but when she goes home, the pain comes back. So step 2 is what? You said pain management injections, or?
I will consider an epidural injection, specifically a soft tissue herniation like this, because if they're going to improve, they will improve within that period of 4 to 6 weeks as the liquid tends to reabsorb. However, she does have a component of mechanical compression by the osteophyte formation.
At C5, C6?
Correct. So I think the epidural injection will give you the diagnostic information, how much of this is just an isolated nerve root compression by the foraminal herniation versus the stenosis.
Do you guide the pain management people? Or
I always do.
You always do?
I always get upset when they don't do it.
Yeah.
Because if I want to do a transforaminal on this guy, and you send it without an instruction, they're going to do an interlaminar C71 or C81 because it's safer for them. You know?
So what would you, in this case, what would you instruct the pain management?
For this
position?
one, I will definitely send it, if possible, also selecting a root block at C6, C7.
So left, you would say left C6, C7 selective nerve root block.
Yeah.
Okay.
And I will give you an idea. If they have severe pain, I will do it interlaminar because it will have bilateral spread and it will affect the stenosis. But if you want to know how much of this is just an isolated nerve root block, then you want to select a nerve root block.
Okay, so you would start with a selective nerve root block, left C6, C7. Correct. And would you change the medications at this point? Would you add something?
I usually don't. I will defer the any narcotic medication for comfort to the pain provider. But if when I used to do them, I used to give them a very short-acting narcotic just to get them comfortable. If they're able to sleep on the supine position, you know, most of them they can. So I just give them a little bit of hydrocodone or something like that just to get them comfortable at night.
If the patient says they can't sleep.
If they can't sleep.
Do you give patients soft collars?
I am not a big fan of collars, and I do understand the rationale behind it. And some people feel comfortable when they do. I tell them to use it upside down. I mean, with the closure in the front because it's narrower. So the chin part, which goes in the occipital region, will force them on flexion, which is a position of anatomical advantage. If they go on extension, they won't tolerate because pretty much you're creating closure of the foramina. And if they have any compression too, the maximum diameter of the spinal canal narrows down on extension. So you always want to have either neutral or slight inflection position. And if you reverse and tell them, hey, listen.
And it kind of forces them in that slightly.
You just force them with a slide. It's about 10 degrees of flexion. Similar to the position that we use when we used to do the injections, just to open it up. When you have it in the room, just have it. Try this. See how it feels. How you feel better, like this, or with the closure on the front, and they will feel a lot better. Also, that allows them to talk and eat, and the compliance with the soft collar as well.
Why don't you like the soft collar? I'm just curious. You understand? I ask these questions because I learned from you.
That's fine.
Yeah.
I find that people that become if they like it, they're going to use it all the time. And within a period of 4 to 6 days, they get really weak. They lose a lot of muscle tone, specifically the tonic muscles, as the postural muscles.
Yeah.
So recovery for those usually takes a bit longer. While they're in physical therapy, they notice that because they're the ones, this week, but they've been using the collar 3 to 4 weeks before they come to see me and so on.
What about at night? Just tell them to use it
at night. Is a perfect use for it because it prevents her drifting sideways and waking up with that impingement. So it's a good thing. I tell them to use those C-shaped forms if they sleep on a recliner, the one that we use on the airplanes, so they don't drift sideways, or they can use a soft collar.
Yeah, most people have that C-shaped collar. You get it at Bed Beyond for like $10.
It is cheap.
Yeah. And when do you start a medication, say like gabapentin, or do you have any policy for that, or
the gabapentin I use
muscle relaxer?
Well, muscle relaxing, they have reflective muscle spasticity, which frequently they do.
They'll tell you that usually, right?
They'll tell you.
Yeah.
They'll tell you. I can use them concomitantly with the oral steroids, and it's because that allows them to sleep and it gives them 10% relief, specifically for the musculoskeletal pain. The gabapentin is a great medication, but I try to avoid it until either they have 6 weeks of treatment, just to see where are they going. I guess pain for me is a meter gauge of where the condition is going to get better or worse. and of course determine if the pain becomes untenable, um, and it's looking into a more surgical direction. I use them just for palliative typically. Um, I reserve that medication usually post-surgical for some of the residual paresthesia. If the paresthesia is indeed disruptive, you can use the neuroleptic medication, the gabapentin, the Lyrica, as not only a pain relief for a neuropathic component of their discomfort, but also an anxiolytic and sedative. They sleep better with it.
They sleep better with gabapentin and
That's
Lyrica.
right, they sleep better. They do sleep better.
Okay. There's donuts if you want some, Jenny, and right there. Okay. All right. So the patient's going to pain now. When do you refer to a surgeon? Do you wait till after pain management?
No, there's some red flags I look for. One is progressive neurological decline, specifically weakness, ongoing weakness, atrophy, and duration of it. They come to me and they already have a weakness of 3/5 on a specific myotomal direction that point out and correlates with my radiographical and clinical examination. And he has 6 weeks to 8 weeks of symptoms that are continue progressing. They are functionally disabled. By that we mean that actually they can't function at the period they living. They have problems doing the ADLs and they can't work because the pain is unbearable. You pretty much don't want to wait. And the reason for it is you are working on the premise that there's ongoing axonal damage. So the longer they have the axonal damage, the lower the rate, the longer the prognosis for neurological recovery. Also depend on the age. You know, my younger patients, they are more resilient, more plasticity. So if they have a subdisc herniation, they do have a wider period of time for the neurological recovery to happen. If they're younger than 50 years old, the nerves are plastic. You can insult that nerve, you can mush it, and they will recover. Over the age of 50, the neuroplasticity happens at a lower rate. So if they have multiple medical comorbidities like diabetics and all that crazy medical conditions that can hinder the neurological recovery, you have to put all that in perspective. But for me, the indication for surgical treatment is ensuing or progressive neurological decline, disruptive of activities daily living, self-care, and duration.
All right. Any questions so far? Any questions? Okay. So these are just a couple of images of a soft disc in the posterior lateral corner of the disc space, which is compressing the nerve root as it exits that level. And this patient has exactly this disc herniation. And you can see the two nerve roots, dorsal and ventral, coming off the spinal cord, and it compresses it there. This is a cartoon of the osteophyte formation from the uncus, which this patient has as well. And you know, Katie, when we're doing the surgery and I'm putting that 3B curette, that's where I'm putting that 3B curette. Just in it. Yeah, and if I can put a 3B curette, that means we have a lot of room. And this is just a cartoon of generalized all the different abnormalities that you can find on an MRI scan. So our patient has a soft disc herniation and she has an osteophyte in the uncus. So this is like a busy slide. Yeah, it's a beautiful cartoon, actually. You can look at this maybe sometimes later. So this is an article from 2015 of the incidence of abnormal bulging discs in people at different ages. And you can see, I mean, at 50, which, you know, because I'm over 50, that's not that old. Everybody, right, Tanya? It's not that old. Oh, I'm sorry. I'm sorry. I'm sorry. Most patients have abnormalities in the discs, so it's very, very common and probably normal to have abnormalities on your MRI scan. But the incidence of spinal cord compression is not so high at the age of 50. Less than 10%, but as you get up to 60, 70-year-old, and you know, a lot of our patients are 70. We say like probably a third, maybe half. So people come in our office 15% are going to have spinal cord compression. These are asymptomatic patients. These are patients with no symptoms whatsoever. So if you go to Kohl's and walk around the department store and see a 70-year-old person, 15% chance they have spinal cord compression, and they're just living with it. These are just a cartoon depiction of C5, deltoid biceps tendon, and you see the sensation. C6, wrist extension, brachioradius tendon, and you see thumb, index, middle finger. That's our patient's presentation. C7 is wrist flexion, triceps tendon, and C7 usually goes middle finger, but I have found index, middle finger, ring finger usually. And C8 is intrinsics, no real reflex, and sensation is the fifth finger, fourth finger. And the other one I don't have is T1. T1 also can affect the hand, intrinsics. So patients many times say this to you: when I put my hand on my head or when I put my hand on the top of the car, it feels better on the roof of the car, and it just decreases the stretch of the nerve root. So normally, you see top left, there's a large spinal canal, plenty of room for the spinal cord. This is just dermatomal distributions. Our patient is the thumb, index finger. You see that C6. So this I like to think about this all the time, and maybe you can add to this, Walter, is other things that can give you the same symptoms. So C6, C7 could be carpal tunnel syndrome, but usually those patients do not complain of neck pain. C7 could be posterior interosseous nerve, which is rare. C8 could be cubital tunnel, pressure on the nerve at the elbow. Angina can give you arm pain, RSD, thoracic outlet syndrome, Parsonage-Turner syndrome, which I probably see once every 2 years. And a C5 pain could be a rotator cuff. So all these things, and the other thing is patients can have both, have C6 radiculopathy and carpal tunnel. Can you add anything to that, Walter?
There are two conditions that actually always throw you overboard. One is on the patient population over the age of 60, they present with a severe pain on the cervical thoracic growth and weakness. It's called polymyalgia rheumatica, and they present with weakness and they can't raise their arms and they have pain, and it's pretty much more diffuse. But some of this, when you have a simple herniation, they can give you mechanical axial pain. I can present with that. And of course, the biggest masquerader of all is multiple sclerosis. Multiple sclerosis can affect a specific nerve root, particularly myotoma or.
That's the next one.
There it is. Those are the systemic ones, and those are the ones that always gotta be in the back of your head.
So ALS, you said multiple sclerosis. Myelitis, usually these patients have a fever or they're sick. Debalaminating condition, the same thing as multiple sclerosis, really. Intracranial, syringomyelia.
Syringomyelia. We just recently had a patient that actually has diffuse syringomyelia, syringobulbillia. I mean, from the fourth ventricle all the way down to the spinal cord. And she presented with a C5 radiculopathy presentation. Even the nerve test shows C5. Mm-hmm. And we know it's a chronic one, but there is 80 to 90% of dilatation of the cord. Mm-hmm. The only thing you have left is just some strands. Mm-hmm. And amazingly, she had no cortical strands.
Yeah, it's interesting. I mean, central problems they look like they're focal, peripheral. Just about the we didn't say surgery. So just a surgical approach for an anterior surgery is transverse incision is just, I think, aesthetically more pleasing. You cut through the platysma, and then after the platysma, you see on the top, you go between the sternocleidomastoid muscles and the strap muscles. Then you see next you encounter the carotid sheath, and that's why, Katie, during the surgery, I stop and I put my finger there, and that's what
you want to feel.
Yeah, I want to make sure I can feel the pulse, and then because you can be on the other side of it, and then you stretch the carotid during the case, which is bad, or you can go right through the carotid sheath. If you go through the fascia, you can go through the vein and the artery and the vagus nerve. So that's why I'm always got my thing. Make sure the carotid artery goes towards me on the left. And then the esophagus is on your side, and your retractor pulls on the esophagus, and then you get down to the vertebral body. So that's something that should always be like in your mind when you're doing these cases. And of course, you can injure any of these structures intraoperatively. So once you get down to the bone, there's a sheath, a fascial sheath that opens up just before the disc, the prevertebral fascia. So this gives you an idea of the recurrent laryngeal nerve. So on the left, the recurrent laryngeal nerve has fewer aberrant courses. So in other words, the left is usually always like that. The right can vary a lot. So the right side, the recurrent laryngeal nerve can be right where your surgery is. So because of that, this is all theoretical. Because of that, it's safer to go on the left, but that's been disproven by many studies. So it's not clear what the right way to go. You can go either right or left, but you have to understand that there is some data that says the right is more variable. So you have to watch out for the recurrent laryngeal nerve. If you injure the recurrent laryngeal nerve, you become hoarse. So that's why I always go left. It's better to go right if you're right-handed, because then everything is like with your right hand. Mm-hmm. But if you're used to it, you don't care. So that's why I always go left. And this is just what the surgery is like. And you see the bottom, you see the drill is in the disc space going towards the uncus. And we use pituitaries, we use high-speed drills, we use Kerrison punches to remove the disc and take the pressure off the spinal cord. The curettes look something like this, although this is the older Codmans. I have the newer Codmans. These are micro curettes that pull the disc material out. And so basically a fusion is when you weld two bones together, like two cubes. You weld them together. And the way you weld them together is that crack between the bones. You have to stick something in there. I use the bottom left, a cortical cancellous composite. I won't get into why I use that, but you can use iliac crest. You can use other things. And you can use a plate and screws to hold everything still. There's also standalones now. I use a microscope when I do it. I feel it's safer, it's easier, I see better, and my assistant can see everything. So you see everything, right, Katie, during the assistant, which is nice. And this is the microscope I use, the top left. It's the Leica 6. It's the newest one. And if you put the vertebral body in the front of the spine, there's compressive forces, so it's more likely to fuse. But cervical spine always fuses. Okay, so now what to do? So any questions so far? Yeah.
What treatment is going to do a discectomy compared to the rest of the fusion?
When would you do a discectomy only versus a fusion?
At what point would you decide to do the fusion?
Yeah. So a discectomy for so when you say a cervical discectomy, what you mean is the word that we use is posterior cervical foraminotomy discectomy. So you can drill. You weren't in yesterday's case, but yesterday's case I did do a foraminotomy. So you can drill a hole where the foramen is posteriorly, and you can tease a piece of disc out, and you don't have to fuse it. I rarely do that case. Because I think you get better lasting results with the anterior cervical fusion. A foraminotomy will not treat the central spinal cord compression. So the best indication for foraminotomy discectomy posteriorly is usually it's a young person with a very soft disc that's bright and it's easy to fish out. Having said that, those patients, they don't need surgery. So young people, soft disc, they never leave Walter's office. I think they get better. You think so?
Yeah, I agree.
Yeah.
One of the things that I do always judge, if they need it or not, is how much component of mechanical discomfort they have, how much degeneration. Some of these cases, you just go and do just a plain discectomy. What Dr. Antonides is referring to duration is that they just speed up the degeneration of the disc. So they go on to develop mechanical pain or axial pain. So they feel uncomfortable you can't take the radicular component out, but they remain with pain and even motion.
If you don't do a fusion.
And exactly, those are the cases that go on to have revisions for a fusion afterwards.
But no, so like this lady, so in this woman, that soft disc, you could possibly do a discectomy, but you see it's also central too. You see, can you see that? That like that disc is behind the spinal cord. So I mean, it's possible that you can fish that out, but you can't retract the spinal cord. So the best soft disc herniations are in the foramen, like away from the spinal cord, and they're soft, so you can pull them out. But those are very, very few cases, and also those patients don't need surgery. I mean, I feel they get better. Yeah, they go away. Yeah. So the way they go away is you grow blood vessels into them, and then the blood vessels sort of white blood cells exit the blood vessels and eat up the disc, and the disc is gone. So you do an MRI 2 years later. 6 months later, and it's gone. Okay. One second. Okay. All right, so in this case, I elected to do a 2-level ACDF, C5, C6, because there's central stenosis from an osteophyte compressing the spinal cord centrally, and then C67 to remove the disc fragment. And then I used the plate and screw and allograft. So this is just some this is the surgery under the microscope. And this is level C6, C7. So to the right is the patient's head, to the left are the feet, and I'm on the left, and that's the microcurette that I told you. And I'm down to the spinal canal. I've removed the whole disc, and the very center of the disc space, I'm lifting the disc material off the spinal cord in the dura. So I've seen the dura. It's very bright white. And so I know where I am once I know that. And this is the offending fragment. I put it slow motion because it's like the NFL highlights. That's the disc. That's the disc fragment. See how big it was?
Yeah.
And that thing was underneath the PLL compressing the spinal cord. So that was probably most of her symptoms. But she also had central stenosis at C5, C6. And then I usually take the whole disc out, take the whole disc out, expose the whole dura. But I mean, you don't have to, but it doesn't take that much work. I like to remove all the discs because I always have a concern that when I'm tamping in the bone graft, if there's disc material there, it could push into the spinal cord. So I feel it's safer to take it out as long as it's easy and safe, which is not always the case. Sometimes it's really scarred or it's difficult. And then this is just, although I did remove one big fragment, I think I should be sure that there's no other additional fragments because it's not always just one piece. Sometimes it's 2 pieces, 3 pieces. You don't know. The MRI doesn't tell you that. It cannot tell you that detail. So intraoperatively, you have to be sure that you removed everything that could be compressing the disc or the spinal cord. So we can just watch this for a moment. So any questions about like the surgery? And this is just removing the more disc material. You kind of get an idea what the surgery's like. That's like a Kerrison punch. That's a 1 millimeter Kerrison punch. And Katie's trying to suck off the material off the Kerrison. She's my assistant, and I'm just always the curette is always going away from the spinal cord. So I go just underneath it. It's a 1 millimeter curette, and I lift up, and then I try to remove it with the Kerrison. So this is like a tedious process because you have to be slow and careful. You see the Kerrison there removes osteophyte. So there's always osteophyte from the end plate. So any questions about what the surgery's like? Discectomy, anterior ACDF? Anybody? Okay. See if there's anything else interesting. So after the disc is removed, I put the corticocell allograft composite, and then a plate screws holds everything still. And this is the post-op X-ray. I know on the AP view the plate looks crooked, but as long as you're within the vertebral body, it doesn't matter what your plate looks like. We try to get it perfect, but I don't think it's worth going through a lot of effort because it doesn't make a difference. So that's it. So any questions about anterior cervical fusions? Anybody?
What is the recovery?
Katie, why don't you tell Jenny what the recovery is like? Like, Kate, tell
Yeah.
what in the recovery room, what do patients usually say? They have these soft disc herniations and arm pain.
Is recovery like right
Yeah.
after surgery?
Yeah.
So they, well, I mean, they're still waking up, but if they feel cervical radicular pain down their arm preoperatively, their pain is almost immediately gone. If not 100% gone, maybe it's 80% gone, but they do feel an improvement. Their biggest complaint and something that we worry about is because as his assistant, I'm retracting the esophagus and the trachea during surgery. Sometimes a big complaint is, oh, I have a sore throat because I'm pulling the trachea, or we want to make sure they don't have difficulty swallowing food or even swallowing liquids. That's something that we look for. It's rare for that complication to happen because they're very safe during surgery, but a sore throat is common, and we just treat that with a common cold.
For the benefit of therapists and me, post-surgically, for how long do you keep them on a collar, and when are they allowed to get some sort of mobility through either therapeutic exercise? Most of them don't need it, but those that actually, the deconditioned elderly patients that we send, when is it safe for us to actually fool around with those necks?
Right away. So I think, okay, so the old days, the plates weren't so good, or we didn't even have plates. So everybody got a collar for 6 weeks. You can't take it off or everything pulls apart, and the graft can spit out. So then they came out with the plates that didn't work so great. Sometimes the screws backed out, so you had to keep everything still until it fuses. Now the like third generation screws and plates, they almost never fail. It's very safe. It's been studied. So I'll tell patients to do whatever you want. But having said that, I say you should wear the collar for 2 or 3 weeks until everything settles down, everything calms down, and then you can take it off as needed. You can take it off at night. You can go to physical therapy right away. Just use pain as a guide. Because I feel if you don't give a period of rest, you don't get better. So the nerve's inflamed, irritated, like a broken bone. You put it in a cast and it calms down and it can heal. So I usually say 2 or 3 weeks, but I tell them they can also take it off.
To go along with that, so because I see patients in the hospital afterwards, even though they are wearing that cervical collar for 2 to 3 weeks, I do tell them that yes, you had neck surgery, and yes, you're wearing this collar, but don't be afraid to move your neck. In fact, I encourage you to move your head up and down, slowly, laterally, left and right, because if you don't move your neck, you just are going to tighten those muscles, and your surgical pain may tighten because of that.
Yeah.
So it's kind of like National WD-40. Like you want to.
Yeah, and you can get RSD. You can get complex. Yeah. So, yeah. So I really, it's important. People. I have a mantra is like get back to your life. So, maybe go to the gym. Just walk into the gym, and just say hi to everybody, and just go on the treadmill for 10 minutes. So, start going to work right away. I think it's important to go back to your life. So what else? Any other questions about ACDF, about cervical radiculopathy?
When do you decide to use plates that we use versus those standalone devices?
I don't know. Okay.
I'm still trying to figure out why we do
Yeah.
what we do.
Yeah. Okay. So there's some areas in particular that are high risk for dysphagia. Older people and C3, C4, because they're higher up by the swallowing center. So I have a higher probability to use those higher up in the swallowing center. Also, I use those for skip lesions. So
right, and yeah.
Yeah, so you have C4, C5, and C6, C7. You can put 2 plates on. Apparently, the standalone devices are just as good theoretically, but I feel the allograft has a larger footprint. Like that whole footprint of the allograft is going to fuse, while the standalones just have these holes. So you're like relying on a smaller area to get the fuse. And also the standalones, you can't see non-unions post-op. So patients come back 2 years later, you can't diagnose a non-union because of the implant. But with the allograft, it's very clear, you know. So I feel responsible for patients their whole lives. Like, you know, I expect to take care of them until they die. So if they come back in 3 or 4 years, they're kind of still my responsibility, my patient. So I want to know if they healed or not. So that's why I like to use the allograft, but I don't feel very strongly about it. Does it answer your question?
Yeah.
Yeah. What else? Any other? Okay. And there's one final thing is Saturday at the Inner Harbor. This is Tuba Christmas. Me and my son are playing in the Tuba Christmas. It's free. It's a Christmas concert. I think it's 5 o'clock. So usually the Ravens band always comes. And there's usually like 40 members from the Ravens band. And me and my son will be in the front. I think we're in the left, the front of the left. We have euphoniums. So just for anybody's interested, this Saturday, free Christmas concert.